Yeah, my arm's been numb, like, you know, the whole time you've been doing this, and now you can't feel anything, right? So you just wasted time. But check that pulse-motor sensation before and after. Okay, number 15, talk about shock again. 15 and 16, talking about shock. Do you see just how important shock is? So when your body's perfusion is interrupted, you go into shock. What are the expected vitals of someone for each different type? All right, how do you treat them? Okay, so we'll just start with number 16, the early and late. So the early or compensatory shock, the early phase, remember you have tachycardia and normal blood pressure. All right. So if you see your patient, experiencing some kind of emergency, whether it's medical or trauma, okay, I know this is the trauma module, but some kind of emergency, and they are tachycardic with normal blood pressure, investigate that tachycardia because there's something causing it. It may be pain, it may be fear, it may be anxiety, but there's something causing it. All right, and you want to make sure that it's not something that is shock, right, or something that can lead into shock. If your patient is tachycardic and hypotensive, then you know your patient is in shock, and they're in that later phase of that decompensated shock, right? Trauma, the biggest one is hypovolemia, hypovolemic shock, which is a volume problem, which means we're most likely bleeding externally or internally, right? If it's an external bleed, then you control that bleed, right? If it's an internal bleed, then you can put pressure dressings and rapid transport. We always want to keep our patients warm. We always want to give oxygen to any patient that's in shock. So high flow O2 with that non-rebreather and keep them warm. If the cause of shock is something that we can address and something that we can fix, like if it's anaphylaxis, then give them epi, right? If it's cardiogenic shock because they're having an MI, then start your aspirin and your nitro and your oxygen treatment if it's not contraindicated in that patient, right? If they're already in decompensated shock and they have hypotension, then you may not be able to give them nitro, but you can still give them aspirin and oxygen, right? If they have neurogenic shock again is something that can happen from trauma because it's a spinal cord injury. Neurogenic shock is a form of distributive shock. So this is a spinal cord injury. So you most likely you're going to be putting your patient in C-spine precautions with your C-collar and putting them on a backboard to make sure that nothing else moves and all that kind of stuff. You're securing their spinal cord, right? But hypovolemia and controlling that bleeding. So let's talk about bleeding control real quick. So the arterial bleed is that bright red pulsing or spurting bleed, right? Your venous or venous, however you want to call it, bleed is your dark red flowing steadily, not pulsing, but flowing steadily bleed. And then you have your capillary bleed, which is, again, dark red, but it's kind of oozing and it's kind of a slow bleed. I normally don't have to. Capillary bleeds are normally not life-threatening, but arterial and venous can be. So if you have an extremity bleed, an uncontrolled bleed on the extremity, the first thing is direct pressure, right? Direct pressure. And the pressure that you're putting on your patient is supposed to be it's supposed to overcome the pressure of the blood leaving their body, right? So a lot of pressure. Then if it's on their extremity, arms or legs, then if the direct pressure doesn't work, then you use a tourniquet. You just go straight to a tourniquet, okay? You can wound pack an extremity if needed, but you're going to try that tourniquet first. Okay, it's quick, it's easy. You crank that down, you crank the windlass down until the bleeding stops and you no longer have distal pulses. Okay, so you have to keep in mind that when not only are we stopping the bleed to that injury, but we're stopping the blood flow to that entire extremity, right? Distal to the placement of the tourniquet. So that's why it's so important to put the time when we place that tourniquet. The tourniquet is normally placed about 2 inches above the site of the injury. Okay. And like we said, crank it down until the bleeding stops and you no longer have distal pulses. If the bleeding starts up again, then you leave that initial tourniquet in place and you place a second one above the first. crank it down again until bleeding, bleeding stops and distal pulses are lost, and then you put the new time of the second tourniquet. Okay. Now, if you have a patient with an uncontrolled bleed in what we call those junctional areas, junctional meaning your axilla and your groin, places where I can't use a tourniquet, then that's when I'm going to use that wound packing. First thing I'm going to do is direct pressure. You will always, always, always do direct pressure first. But if that doesn't help, then I'm going to go to wound packing. And remember, wound packing is where I'm pushing that Kerlix and that gauze inside the wound, and I'm basically causing, putting pressure on that wound, but from the inside, so it'll stop bleeding. I put as much in there as I can. And once I can't get anything else in there, you want to wrap that sucker to make sure that gauze doesn't shift, doesn't move, doesn't come out of the wound. Okay. And then if you have bleeding from the torso, the torso, you cannot use a tourniquet. You cannot wound pack in the torso, right? Whether it's the thoracic or the abdominal cavity, you can't, because it's a cavity and it's not going to work, right? So if it's if you have direct bleeding if you have external bleeding from the chest or the upper back, so anterior or posterior chest and upper back, direct pressure with the gloved hand and put an occlusive dressing, because you have a hole in the thoracic cavity, right? We've talked about that. Put that occlusive dressing, and then you can wrap it. If it's in the abdomen, the anterior abdomen or the lower back, then direct pressure with gauze. You might need to use moist gauze, especially if some of your internal organs are present or exposed. And then wrap it again with just some pressure gauze. You want to keep pressure on it, and that's rapid transport. Okay. Because unfortunately, because we can't stop the bleed with either a tourniquet or wound packing, then this is a rapid transport. We got to get them going, right? Okay. '17 is talking about C-spine and different kinds of different kinds of injuries that occur from C-spine problems. So paraplegia, your paraplegia is going to be when you have, hang on a second, I'm reading this, hang on. Hemostats, let me see here. This is on our thing. You can use hemostats. You can use hemostats on extremity bleeds. You can use hemostats on junctional bleeds. You can use them, yes. Just to help. You absolutely can. Hemostatic agents that can, like quick clot and things like that, or the chitin and things like that. There are some pressure bandages that actually come with hemostatic agents in them that will help with stopping the bleed. So you absolutely can use that if your agency carries it. Okay, paraplegia. So paraplegia is the paralysis of the lower limbs and the trunk. They still have use of their upper limbs, but they have paralysis of the lower limbs and the trunk. Okay, hemiplegia is going to be one side or the other. Hemi is always side, right? So hemiplegia, one side paralysis or the other. Quadriplegia is paralysis of arms, legs, and trunk. Okay, so a couple things that we worry about with our C-spine. Paralysis is definitely something that we worry about because that's just a terrible injury to have to sustain for the rest of your life. However, I do want you to think about all of those really important nerves that come off of the C-spine. Your cervical spine has a lot of important stuff. One of the most important is the phrenic nerve, which tells your diaphragm to work. And y'all remember how important the diaphragm is. That's the muscle that helps us to breathe. So not only are we worried about when we're talking about cervical injuries and paralysis, we're also worried about breathing, heart rate, things like that. If you have specifically, we'll talk about specifically if you have an injury at C3 or above, you lose the ability to breathe because that's where your phrenic nerve is located. Okay. Minimizes the ability for the chest wall to expand. Got all kinds of problems that can come off of your cervical from cervical injuries. Now, paralysis can happen anywhere in your spinal cord. It doesn't have to be just your cervical vertebrae, right? It can be anywhere. Okay. Rapid head to toe versus focused. So a rapid head to toe needs to be done. And a rapid head to toe is a 10-second head to toe assessment where you're looking for life threats. This absolutely needs to be done when you have a patient who is unconscious or semi-conscious and they're not able to talk to you and tell you, what's wrong. Okay. So if they're unconscious or semi-conscious, or they have a decreased level of consciousness, how about that? Then you have to do a rapid head to toe to look for life threats. Have to. If your patient is awake and talking to you and you cannot see any bleeding or anything like that, then you don't necessarily have to do that. Because they should be able to tell you what their chief complaint is. Should you still look for active bleeding? Yes, right. But if they're talking to me, then I know they have a good airway. If they're talking to me, then they most likely have a good breathing patterns. But I should still do a quick look for any bleeding that's occurring. But in absolute, if they're unconscious or with a decreased level of consciousness, you must do a rapid head to toe. The focused physical exam, that's the one that we've been having you guys practice and really work on, because that's the one where we're looking for everything else. We're going through the head and we're looking at the skull and we're looking for all of that decap BTLS stuff. We're looking at the pupils, we're looking in the nose and in the mouth for any bleeding, in the ears for any bleeding. We're looking for battle signs. We're looking for tracheal shift and JVD, and we're feeling the C-spine for any kind of pain or what we call step-offs. Step-offs would be if something is a vertebrae is kind of sticking out or it's not in line, and we go all the way down the body and we're looking at looking and feeling, right? Palpating, because there's a difference between a patient having pain, spontaneous pain, and then there's a difference with pain on palpation, right? It hurts when you push on it versus it doesn't hurt at all. So that's your focused head to toe, and you have to do that on all your patients, specifically the ones who are awake and able to give you, well, not specifically, but you got to do it on all your patients, okay? Rapid head to toe is a must on your unconscious to find those life threats. Okay, I'm not going to go over step by step of this, placing your patient in a C-spine and putting your patient on a longboard. You guys can see that on your skill drills. Okay, and I'm going to find these skill drills just so I'm not leaving you hanging out in the dry here. Okay, let me see here. Where is it? Skill drill 29, 1, 2, and 3. Okay, so if we were to go to our canvas, go to home, come on, shift on down here to the bottom where we have our skill drills, come here, looking for chapter 29, which is right here. It should link you to your book. And this is where you're going to see all your skill drills of your step-by-step of C-collar and backboard and all that. Manual C-spine is always important. This is the first thing that we do. We hold manual C-spine, right? And then you're going to want to measure the collar, make sure the collar is going to fit appropriately. Put the collar on your patient, make sure it's placed appropriately and the chin is actually in that chin little rest right there. I've seen a lot of patients be transported to the hospital and this chin piece right here is actually up at their nose or up by their mouth because it wasn't put on properly, and that's not doing anything for their spine. So let's make sure we put it on properly. Even when the C-collar is on, you hold manual C-spine, right? You maintain that manual C-spine until that patient is on the board. Let's see here. So there's all of that. Then when you actually put them on the board, remember to log roll. Okay. The person at the head is the one who calls the timing, 1, 2, 3, roll, 1, 2, 3, back, however it is you want to do it. Make sure you have enough people on one side, and you see how their arms are kind of interlaced with one another. They're kind of crossed. That will make sure that the whole body of the person rolls at the same time, and it's not going to be like one section versus the other. But roll your patient. Check the back if you haven't already checked the back. You always want to check the back, and we're looking for, again, for decap BTLS or other life threats that we may have missed before we place them on the backboard. Scoot that backboard underneath them, right, up to their side, and then log roll them back on the count of the person at the C-spine and put them back. If they're not in the middle of the board, sometimes it's hard to get them in the middle of the board, then you don't want to slide your patient in a lateral way. You want to do, it's kind of like an upward diagonal thing. Again, on the count of the person hold manual C-spine, you'll shift your patient down, kind of like at an angle, and then shift them back up more into the center of the board. But never shift your patient laterally, because if you do that, then again, you're just manipulating their whole spine, and you're not keeping them straight. Secure their body first. Secure their body first. Head is always last. The proper way to do it is to crisscross across the chest, right, up and over their shoulders. So you want one strap that comes here over the shoulder and down to the other side of the hips, and then on this shoulder down to this side, kind of crisscrossed. One across the hips, one across the lower legs. So you got 4. And then we secure the head. The head is always last. Always, always last. And not until we secure the head, that's when your patient, or that's when your partner, whoever is holding C-spine, can stop holding manual. Okay? So just making sure that we do that properly, and we're not furthering a patient's injury by putting our patient in C-spine and on a backboard. That's the most important thing. Just make sure that it's on appropriately. Brown-Séquard syndrome is what we call an incomplete spinal cord injury. And we're going to go over some of our incomplete spinal cord injuries, not just the Brown-Séquard syndrome. Okay, because there's more than just that one. So incomplete spinal cord. Okay, so when we're doing that that head to toe, and we're looking for decap BTLS, and remember, decap BTLS is deformity, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling, right? So when you're going down from head to toe, and can you feel me touching you? Do you have any pain here? What if someone says, I can't feel that, I can move my hand, but I can't feel you. That right there is an incomplete spinal cord injury. Okay. And so super important to know this stuff. So remember, your spinal cord is obviously within your vertebral column, right? But we're going to go over these incomplete spinal cord injuries. It's going to be kind of hard to see. Let me get that bigger. There we go. So your Brown-Séquard syndrome, if I'm saying that correctly, this is it's a hemitransection. And remember, hemi means side. So it's a hemitransection of the cord. So that means that there's some kind of penetrating injury that came in from the side. Okay. And anything below the level of the injury, you're going to have motor weakness or paralysis. So movement weakness or paralysis on the affected side, and you're going to have loss of sensation or numbness on the opposite side. Okay, so the key down here, if you look at this, white means normal function, red is impaired motor, so they can't move, and pink is impaired sensory, so they can't feel. Okay, so this person would be, it looks like they're looking away. Anyway, on their right side. Okay, if this person is looking at me, then this is their right side. They had something come in and pierce them on the right side and went into their vertebral column, and it got the right side. So that means their right side is paralyzed, but their left side has sensation deficits. Okay, which is odd. They can move their left side, but they can't feel their left side. Okay. An anterior cord syndrome, remember anterior means front. So this is going to be, you know, the front part of the cord is actually harmed. And a lot of times this will happen with hyperflexion injuries, right? When we flex or move forward and it kind of crunches the front part of your vertebral column, okay? So it's an anterior cord injury, okay? So anything below the level of the injury says everything, pretty much everything. Okay. Motor paralysis, loss of pain and temperature sensation. Okay, motor paralysis, loss of pain and temperature, but they know what position they're in. They can feel you touching them, but they can't feel pain or temperature. It's weird. It's really weird, okay? So anterior cord syndrome, they can't move. They can't feel pain or temperature or heat or cold, but they can feel you touching them, okay? Posterior cord syndrome is going to happen with like your hyperextension. So it's the posterior part of the cord, and below the injury, motor function is preserved. So there's no paralysis, but it's all going to be sensory stuff. Okay, pressure, stretches, sensory, they can't feel, that kind of thing. Central cord, this is odd, but this is going to be a central cord syndrome. Again, sometimes central cord comes from hyperflexion and things like that. Okay, central cord syndrome is actually the most common form of the incomplete cord syndrome or the incomplete spinal cord. And I'm sorry, it's not caused by flexion. It's mostly by extension. And there's greater motor impairment of the upper extremities. So I've got paralysis of the upper extremities and sensory deficits of the lower. So paralysis of the arms and the hands. I can still move my legs and stuff like that, but I have sensory deficits in the lower body, but paralysis, motor deficits in the upper body. So different incomplete injuries. So this is where it's not severed all the way through and all that kind of stuff, right? So just be aware of this, you know, and understand just how important it is that we do that head to toe. Can you feel me touching you? Any pain, any issues? Not only are we looking for signs of injuries, right? Like the deformities, contusions, and all that stuff, but we're looking for, can you feel me touching you? Can you move your hands? Can you wiggle your toes? All that kind of stuff. So if you have any of this, then something that keys you in on why can they not move their arms, but they can move their legs? Or why can't they move, but they can feel me touching them? You know, things like that. Okay. So that's the last one that's actually on your exam review. But there's a couple more things that I want to go through. And we'll go back to the top. Wait. Okay. One, I want to talk about helmets. So we talked about C-spine, C-collar, backboards, all that good stuff, but helmets are definitely something that you guys are going to run into, whether it's a motorcycle helmet or like a football helmet or something like that, right? If a patient has an injury and they still have that helmet in place, then there are times where we have to remove it, and there are times where we can keep it in place. So let's talk about it. Okay. Remember when we talked about impaled objects and we said that if it was inhibiting airway management or our ability to do compressions and things like that, then we had to remove the impaled object. If not, we kept it in place. The helmet is very similar to that. Okay. But the helmet, it has to be removed if it's a full-faced helmet. So if it's one of these, you know, motorcycle helmets that's full-faced, it has to come off, because I can't assess and manage my patient's airway and breathing. Okay, so it has to come off. If the helmet itself will prevent me from properly immobilizing the spine, then it has to come off. So if I'm going to be putting them on a backboard or doing anything like that, then I'm going to have to take that helmet off. Obviously, if the patient is in cardiac arrest, I'm going to have to take the helmet off, right? Because I have to do airway and ventilations and all that kind of stuff. So let's talk about how we take this thing off here, because you have different ones, right? You've got your full-faced kind of motorcycle helmet, right? And then you have your sports helmet, which is more like this one, where you can, like your sports medicine individuals can go up and they can remove the face guard. So you can still do some kind of airway, airway management. See over here, they're actually removing it with their little drill, their little, zit thing. So, but if you are removing this helmet, come on, I used to have a really good picture. Basically, all right, we'll just look at this one. This is a two-person move, okay? You're going to have someone hold C-spine from the front as best as possible. This person that's at the head is going to grasp the sides, both lateral sides, by the patient's ears. They're going to pull laterally, pull out, and then they are going to pull the helmet off while the person in front is holding C-spine. That's basically how we do it. Okay. But it's definitely a two-person move. You can't do this by yourself. I'm kind of see this one as well. Okay. Holding C-spine from the front as best as possible. Got your hands. Second person has their hands on the lateral portion, and they're going to pull out and then just slip it off while we're still holding. And then this one right here is probably in the best position to hold manual C-spine afterwards. So those kind of take over. And then we place the C-collar, right? So if the helmet is a full face helmet, that's an absolute, has to come off. If the helmet is keeping me from assessing or managing my airway and breathing of the patient, if it's preventing me from properly immobilizing the spine and placing them on a backboard, C-collar and backboard, and if the patient is in cardiac arrest, then it's an absolute, has to come off. Okay. Trauma itself, when we're talking about trauma, and the actual, like the energy transfer, I want you guys to think about kinetic energy. Okay. Kinetic energy formula. There you go. Okay, so kinetic energy, right here, easy peasy. Kinetic energy is 1/2 times the mass, or 1/2 the mass times velocity squared, okay? So you don't have to know numbers or specific numbers or anything like that. This is more the concept, like especially when we're talking about our minute volume for our ventilations and our cardiac output for our heart. This is important. So kinetic energy is 1/2 the mass times velocity squared. So when you think about the energy transfer that occurs, in an impact, the speed of the impact is the biggest determining factor in the energy. Okay. 1/2 times the mass times velocity squared. So if you have a big old 18-wheeler who's going 10 miles per hour, yes, that's still going to cause some damage because of the size of it. But if it's 10 miles per hour, then it's not going to be as much as if it was 80 miles an hour, right? Or take a little, a sedan style vehicle, right? It's a lot smaller in mass, but if that thing's going 80 miles an hour, it's going to do a lot more damage than that 18-wheeler is going 10 miles per hour. So it's all about velocity and speed, okay? All about velocity and speed. Remember, your solid organs versus your hollow organs. Think about where that seatbelt sits. Okay, if your patient has and is wearing a seatbelt, then the seatbelt is a great safety tool, absolutely. And I will always tell someone to put their seatbelt on. But it also can cause harm. Okay, depending upon, again, the speed of the impact, the angle of the impact and things like that. You can have abdominal injuries, internal injuries, lacerations to the liver and the spleen, injuries to the spine. Those things can happen, you know. So when you're doing your head to toe and you're palpating the abdomen and things like that, you're looking for, not only are we looking for, things that just may have occurred, but we're looking for seatbelt signs, right? There are 3 types of collisions that the body endures in an accident. 3 different types of collisions. Okay, and let me see if I can pull this up for you. 3 types. If I can spell. Okay, here it is. There's 3 types. The first one is when the vehicle hits whatever it's going to hit, whether it is another vehicle, a building, a bridge pillar, whatever, right? Is the vehicle against the object. The second collision is the occupant or the passenger that's inside the vehicle will now strike something or collide with the interior of the vehicle. And then the third is the internal organs of that passenger will collide with the solid structures of the body. Okay, so just think about, velocity and inertia, right? Things are going to keep moving until forces act upon it to stop it, right? So the vehicle stops, then the body stops, then the organs inside the body stops. Okay, so just kind of keep that in mind. When you get on scene of an MOI or of an MVA and you look at the MOI and you look at the frontal damage versus lateral damage versus rollover, you think about the speed of the street that they were on or the highway that they were on, and you're looking at the damage and you're thinking about the things that may have occurred internally for this person. You have blast injuries, 3 forms of blast injuries. We're almost done, guys. Okay, so your blast injuries, you have a primary, a secondary, and a tertiary. Your primary injuries are injuries that occur from the blast itself. The damage to the body is from the pressure wave that comes off of the explosion. So your hollow organs are most susceptible to the pressure wave. Okay, so your I can't think of it. Your tympanic membrane, right? Pressures, stomach, right? Hollow organs. Okay. Your secondary blast injury is going to be injuries that occur from flying debris. Okay, debris that comes flying off the blast wave. That's the secondary stuff. So the first is the blast wave itself with the pressures. The second is debris that is flown from the blast, and then the tertiary injury is going to be when the body is thrown against a stationary object like the ground, or if they were thrown into a vehicle, a parked vehicle or something like that. So they're thrown into a stationary object. So just make sure, again, just like those 3 different types of injuries that occur in a vehicle, there are 3 different types of injuries that occur from blast injuries. So you have multiple things that are going to occur to your patient, depending upon how close they were to the blast and things like that. Okay. The treatment priorities on a trauma patient, always, like we said before, is uncontrolled bleeding first. ABCs, exsanguination, you've got to take care of that uncontrolled bleeding first. So if you're reading through a problem, or you're not just for the test, but you're presented with a patient, once you graduate and get your cert and get your exam passed and you get hired somewhere, that bleeding is the most important piece that needs to be controlled immediately before we even move to airway. Okay. Now, if you've got multiple, people on scene, then you're going to be doing multiple things at once, but that bleeding is priority. Okay. Absolute priority. We talked about how to take care of the different kinds of bleeding, extremities versus junctional versus your torso, tourniquets and wound packing and when we use this and when we use that, okay? We talked about C-spine, we talked about the different signs and symptoms of things, the Cushing's triad with epidural versus subdural bleeding. We've talked about Beck's triad. And I definitely need you guys to have that green, the other half. If you haven't done your green one, definitely get your green emergency chart done. And then absolutely get that blue emergency chart done. Do your Mod 3 group quiz. And yeah, there you go. Make sure you know your burns. And it's all about controlling the bleeding. So, all right. If you guys have any questions, you know where to reach me. I've got this going to be recorded here on Big Blue Button for the following week. And then I'm also going to set it up to where, I get the screen recording and put it on YouTube for you guys. I think we are over. We're not over 2 hours yet. That's odd. Okay, I'm good with that. And then, yeah, we'll be good. Okay. All right. You guys let me know if you have any questions. And we'll go from there.